Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This current series focuses on consent. I hope you enjoy it.
Hello and welcome to this medical protection podcast on reducing risk. This is another in our series on consent, and I'm here today with my colleagues Sam King and Tim Cookson, and I'm Lucy Gillard. And for today's session, we're going to be talking about withdrawal of consent or refusal of treatment. So looking at the pitfalls which can occur when a patient says no to a planned treatment. And we're going to start by actually looking at a made-up case example that has been built using the base of an actual case, but some parts of it have been changed. So Mr. A was a 72-year-old man who presented with a biopsy-proven histologically aggressive squamous cell carcinoma near the bridge of his nose. When he presented to theatre for a wide excision, the actual lesion wasn't visible to the naked eye anymore because it had been largely removed during the biopsy. In the pre-op area, the patient questioned why further surgery was necessary because you couldn't see a lesion there anymore. And the patient said he didn't want to go ahead unless the surgeon could guarantee that he would get it all out. The surgeon explained that he couldn't make that guarantee. And so the patient said, all right, then we won't go ahead with the surgery. And he opted for close observation as an alternative. When the cancer later became locally invasive and required majorly disfiguring surgery, the patient complained that his refusal of treatment wasn't fully informed, as he had not been aware of the possible consequences of refusing surgery. So look, it's clear that competent adults do have the right to refuse medical treatment. In New Zealand, this is formalised under Section 11 of the New Zealand Bill of Rights Act 1990, and also in Right 7 of the Code of Health and Disability Services Consumer Rights, which covers the right to make an informed choice and to give informed consent. But in subsection 7.7, it also lays out that a patient can refuse treatment.
I think that because it's been included in both of these rights that we can refuse treatment shows how important it is to be fully informed about the consequences of declining treatment, because patients often just don't know, do they?
Yeah, and it is part of informed consent is informed declining, and that's why it's under that part of the Code of Rights, is because actually it's all about being informed, and it's just as important to be informed when you're declining treatment as when you're accepting it.
And Right 6 also refers to that, and we'll come back to that a bit later, perhaps in the podcast. And yes, look, it's certainly quite clear that competent patients have the right to refuse treatment, even if their decisions seem just absolutely, totally crazy to us as clinicians. But if we consider that a patient lacks competence, then this is an issue that has to be clarified, because if they're really not able to make the decision not to go ahead with treatment or whatever it is, then you may need to look at the other options for consent to treatment. And mostly this would be through enduring power of attorney, but it depends whether that's been set up or not and enacted and all the rest.
Yes, it's interesting that a patient, even if you consider that they might not be competent, i.e. they've had their pre-med, but the moment they say, no, I don't want to do it, most clinicians at that point would desist, they'd stop. And so you have to consider that the right of refusal only requires a very low bar.
Yeah, I think that's true. And I think that issue with being given a pre-med and what the patient is actually saying in the pre-op area is always going to be a little bit suspect, in that it's very clear that for consent, you actually need to consider the situation that the patient's in and actually make sure that that's optimal. And I think having a patient having had their pre-med in pre-op is not probably an optimal situation to be taking a consent or a refusal.
No, speaking from experience, I remember years ago when I had an operation and had pethidine as a pre-med, and then going off to theatre, and I actually knew the anaesthetist, but I remember looking at him and thinking, "You're not a doctor. You shouldn't be putting this needle in my arm." So if I had declined consent to the operation or to the anaesthetic on that basis, it would have had to have been stopped at that moment. But we went ahead successfully anyway.
So if a patient declines when they've had a pre-med, does that mean that's not valid because they've had a pre-med? So you can ignore that because they've signed a consent form? What do you think?
I think technically, I suppose you could say that they're not competent to refuse, but I think that most clinicians at that point would stop, unless you're talking about potentially life-saving procedures. And, we're all aware of cases, particularly in the UK, where the clinicians have sought a court order before proceeding because of the risks.
And look, competency, obviously you've got to be able to weigh out the pros and cons of treatment. No one really, when they're in the situation just before surgery, they is necessarily going to be very good at weighing up the pros and cons. It's a high stress situation, isn't it?
Yeah, and your reality gets very distorted by the medication that you've had, so you're not in a fit state, so you're not actually competent at that stage.
I think that most clinicians are not in a position to really get down to the nitty-gritty of competence, and I think in most cases you need a psychiatrist to come and certify whether the patient is competent or not to make a particular decision, and hence most surgeons or proceduralists will not proceed, and I would agree with that.
Yeah, it'd be very no means no. It would be very unwise to carry on, even if you felt that decision was being made in a situation where the patient wasn't fully able to comprehend what's going on.
And look, I think we're getting a bit sidetracked here because this podcast is supposed to be about consent. We're not really talking about capacity here. But anyway, I think if there's any doubt about competency and the patient's saying they don't want to have surgery, I think we all agree that the surgeon should not go ahead. Anyway, I think on moving our discussion forward, I think we're going to make it a little bit easier and only think about competent patients. So everything we're going to talk about now is only about competent patients. And I think often doctors can think that when a patient's refused to undergo an operation or a treatment, that their obligation's finished there. The doctor's obligation's finished. All right, the patient doesn't want a treatment. That's the end. I don't need to do anything because the patient said no.
Yeah, but look, they've given you a definite decision, and aren't we obliged to follow our patients' requirements?
Requests, yeah.
Yep. And we've said before that competent patients have got the rights to refuse treatment. So surely that is the end of it. They've refused treatment and that's it. Door closed, bye-bye.
I think that the clinician would be best to provide enough information so that the patient can make an informed decision around refusal. And so if you think about the process you go through to obtain consent, you have to go through a similar process in order for the patient to say, no, I definitely don't want the surgery. They've got to go in with their eyes open.
Yeah, and every year at Medical Protection, we see complaints arising from where patients have refused treatment and then there's been an adverse outcome, and the issue will be around that refusal. And look, the issue in the case that we started with, the patient had actually initially agreed to the wide excision and only refused to proceed during the discussion in the pre-op area. And the patient actually was having other surgeries that day, and those other surgeries went ahead. And unfortunately, as is so often the case, because that discussion occurred in the pre-op area, it wasn't well documented, and there was nothing in the notes recording what the patient had been told about the possible consequences of not going ahead with surgery.
Yeah, it's not uncommon for conversations that occur in the pre-op area to be poorly documented. Often the patients are being seen between cases. There might not be a workstation where there's a computer readily available. The paper file may not be there. There are lots of reasons why it's very difficult to document those conversations. But the reality is that does need to be documented. What do you think, Tim?
Yeah, well, it's these situations that are outside what we normally do and what we normally expect that actually, that's when documentation is even more important than it always is. But conversely, as you pointed out, it's actually less likely to be done in those circumstances. And so the difficulty there is that if we don't have that little warning bell going off saying that we need to do something, write something down, if there's a complaint, we can't actually say at that stage, well, my usual practice would have been to do X, Y, and Z, because in fact, this is not a usual situation and you don't have usual practice. So yeah, I think plan needs to be made at the time and recorded at the time. And it doesn't necessarily have to be detailed, that recording, but it has to be enough to make sure that the next steps don't get missed.
Yeah, and look, the surgeon in this situation clearly couldn't have gone ahead with doing the excision when the patient had said no. But then we've got to ask ourselves, is there something he could have done later to avoid a complaint? Because obviously this case did end in a complaint.
Yeah, well, and the complaint is that he didn't understand the full consequences of not having the further surgery. And so clearly there's a gap here. And when a patient refuses treatment, I think we really do need to try and arrange a later appointment with them and then have a full documented discussion about the consequences of declining treatment. So he fully understands that, yes, if this cancer gets away on him, it may not be immediately obvious to him, but actually by the time it becomes obvious, he may need, as he had, major disfiguring surgery. Mm-hmm. And look, that kind of detail of discussion is just clearly impossible to have in that pre-op situation where you're just about to take scalpel to skin. You just can't do it.
Absolutely agree, Tim. And look, I think what we're going to talk about now is what that discussion should look like. So I think what we're saying is, if a patient is refusing treatment, it's not always the right time to have the discussion. Maybe you're going to bring them back later. And then you're going to want to go through a few things just to make sure you've covered that your obligations as far as making sure that patient is fully informed. So Sam, have you thought about anything that we'd want to make sure we covered in that appointment?
I think it's probably the first thing is to document that the patient has been offered treatment, but they've declined it.
Yeah, and look, the other big thing is that we've documented the consequences of declining treatment and what they might be. And obviously we never really know for sure what the consequences of declining treatment might be, but we do need to include the worst possible outcomes, because unless the patient is aware of what the adverse outcomes can be, then truly they can't say that they're declining it with that information.
And this is probably a good time to actually think about, well, are there any other alternatives to the original planned surgery that might achieve the same outcome? And if so, then the pros and cons of those treatments need to be discussed and documented. And as we mentioned briefly, this does relate to Right 6, 1B of the Code of Patient Rights, which is the right to be fully informed. And specifically, it talks about an explanation of the options available, including an assessment of the expected risks, side effects, benefits, and costs, if applicable, of each option.
Yeah, so it's quite an involved discussion to have, isn't it? And to document, obviously. The other thing I think is a good idea is to keep the door open for the patient and actually to say, look, we're discussing this today. You said you don't want to have the surgery at the moment. These are your options should you want to change your mind. And actually, shall we pencil in another appointment in another month or two's time, and we can have a think about it again then, so that you've actually got some kind of follow-up plan in place, where you can again ask the patient to reconsider and consider options. Now, sometimes that's not applicable, and that actually this is their only chance to have that surgery. And if they don't have it now, then that window of opportunity is going to be lost. And in which case the patient needs to know that actually there's no coming back to make a decision later.
But there may be other scenarios, like in general practice, for example, where you believe that someone would really benefit from being on a statin, but they've refused. And in fact, in that situation, because it's not time critical, you can come back and have those conversations at a later stage. And unless you get an absolute edict from your patient saying, I never want you to raise the question of statins again, ever with me, doctor, then it's worthwhile trying. And some people 2 years later will change their minds. So it's not a final decision.
Sometimes it might be helpful to get a second opinion so that they can hear it again from a different clinician, and that might help to persuade the patient. But I actually think it's really helpful if you can involve their whānau, family or friends, to come with the patient so they can hear what's being discussed and they can support the patient, but also be aware of the choices that the patient's been offered. And I think that that's probably protective for the clinician as well as the patient.
What, that the family knows that the patient has made an informed decision to decline treatment?
Well, also because they're listening to the reasons for why it's important to have the procedure or have the treatment, that they can encourage the patient. or talk to them about it afterwards. And
they may end up changing their minds because
that's right.
They've sort of heard things in a different way to what one of their
That's
relatives does, and then when they have the discussion, oh yes, okay, I get it now. Let's go back and schedule that in. Now, another thing in terms of protecting ourselves as clinicians, and we often get asked this, is if a patient has refused something, like in this case with the surgery, should we get them to sign something to say that they're declining treatment? Now, the problem with this is often the patient's a bit reluctant to do that. It seems like a bit of a barrier, really. And there's actually no legal requirement for the patient to sign such a document. But of course, you do need to make it clear in the notes that this is what their decision has been. And although the signed document could be helpful, it's not necessary. However, we realise that it's not uncommon, for example, for someone who's leaving ED against medical advice to be asked to sign a document saying they're leaving of their own volition and against medical advice. So there's certainly a precedent for this kind of documentation to be recorded. The other thing it might do is that actually it might help reinforce to the patient that declining treatment is actually a significant decision that needs really careful consideration. And if they're being asked to actually put their name to a bit of paper, it might make them just think again and think a bit more carefully.
And look, that keeping the door open, I think, is also important, making it clear to both the patient and maybe the GP that if the patient were to change their mind in the future and wish to undertake treatment, that if that is possible, how they would actually go about that and what pathway the patient would have to take to achieve it.
In the case where the patient, you think that the patient may not be competent to consent or decline treatment, it might be useful to have a formal competence assessment. And, GPs often do that, or if they don't feel comfortable about it, then perhaps a referral to a psychiatrist might be appropriate.
And what do you think if the patient won't attend a meeting? Because sometimes in these situations, the patient is saying, no, I'm not going to have the treatment, and no, I don't want to come back to talk to you about it. So no, I'm out of here. What do you reckon about that, Tim?
Well, it creates a gap, doesn't it? Because you no longer have a fully informed patient. They don't really have all of the options in front of them. They haven't had a chance to discuss in detail what the risks of not pursuing with the treatment have been. And so you've got to try and get that information to them in some other way. And clearly documenting that to the GP in a detailed letter, perhaps going through in some detail what the outcomes could be from the lack of surgery, and sending a copy of that to the patient as well so that they've got that information. And again, as we talked about, leaving that door open for the patient to come back and have another discussion about it, even though they've refused the initial invitation to have another consultation.
I think in the situations where there is a refusal of treatment, we probably have to be more careful with the whole process, even more so than when you get ordinary consent for a procedure, which seems a little counterintuitive, but I think that's by far the safest route.
I think it is.
Yeah, I had a difficult case with a GP who had a woman with GI symptoms which clearly warranted a colonoscopy. And he recorded on one occasion that she wasn't keen on having it done. But then she presented a number of times and became anemic, and the indications for colonoscopy were clearly there. He said that he discussed it regularly with her and she kept on declining, but didn't document that discussion. And when it came to the HTC complaint, that was actually very difficult for him to then put that forward as a convincing argument.
As the reason why he didn't refer. Yeah. And I think that's really important. It's not just about surgery, is it? It's actually could be other treatments. It could be chemotherapies. It could be any medication or procedure or whatever. It's not just about declining surgery. It's actually about anything that you are offering as a treatment or as a plan of care that the patient isn't agreeing with.
Yeah, and sometimes the reason for the refusal may be a misunderstanding about what is actually going to be offered as a treatment or management plan. And so, in our case of this man refusing the further surgery, it may be that he had some unrealistic idea of just how significant that surgery was going to be at that time. And so, in this scenario, if you can either talk to him or if he refuses to come to a consultation, at least outline to the GP and to him exactly what is proposed. So he can look at it and say, oh, actually, that's not what I understood was going to be happening. I need to rethink this and have another discussion.
So do you think in this case, if there had been a specific follow-up appointment to discuss the refusal of treatment, that actually that would have avoided a complaint?
Might not have avoided a complaint, but it certainly gives you a robust defence.
Yeah, that's true.
Yeah, and I think it's pretty clear that if this man had a further consultation and the points were specifically discussed, then he would be properly informed as per Right 6 of the Code, and that this was documented, then I would have thought that his complaint wasn't likely to progress far if it went to the HDC, because the facts would be quite clear.
Okay, so this is general advice, obviously, but look, if you've got a specific case and you're a member of MPS, do give us a call on our advice line. The number is 0800 2255 677. You never know, you might get to talk to me or Sam or Tim, or if you'd rather email us, you can email us at nzpodcast@medicalprotection.org with any issues that you think this has brought up for you and any advice that you'd like.
Thank you for listening to this podcast. I hope it's been helpful. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcasts, please subscribe and leave a review.